Good morning, everyone. My presentation is on management of a patient. Management of a patient during pregnancy who has prior renal disease. I would like to thank SLCOG and SLSON for providing with me the opportunity to talk to you. The contents of the lecture would be the background, the pregnancy and the kidney, the approach to care, the common renal conditions affecting the pregnancy, namely diabetes, glomerulonephritis and chronic kidney injury. What is not covered would be renal transplant, urinary tract infections, hypertension, acute renal disease and relapsing and de novo glomerulonephritis. Some of this was covered by previous speakers and some of the others will be covered by later speakers. So there's no guidelines that are readily applied in local setting. So I had to go through various guidelines and find one that could be easily adopted to our setting. BMC Nephrology provides with such a guideline. Most of the contents in this lecture is adopted from the local setting from the above source. So CKD affects 1 to 3% of pregnancies worldwide. The number is increasing with advancing age, maternal age and obesity. So although the renal disease is not a barrier for reproduction, the risk of adverse pregnancy outcomes increase with renal disease. In addition, preeclampsia and accelerated loss of maternal and renal functions are maternal adverse outcomes. And fetal growth restriction and preterm delivery are adverse fetal outcomes. But what is more important is to highlight is that renal disease is not a barrier for fertility. So this has been pregnancy and kidney. This has been earlier covered by Dr. Banagala. So there are anatomic changes like dilatation of pelvic calyceal system due to smooth muscle relaxation, overall increase in renal size of 1 to 1.5 centimeters, and physiological changes such as increase of plasma volume by 50 to 60%, increase of cardiac output, hypotension, increase in renal plasma flow, and increases in glomerular filtration rate about 50%, which manifests as reduction of serum creatinine level. So what is most important is the structure of the care. This is a very important facet in the management. We find large gaps in the local settings, especially with regards to communication between various hierarchies of the healthcare workers. So the management options in pregnant patients with renal disease is recommended to be taken by multidisciplinary teams. These multidisciplinary teams should consist of obstetric, nephrology, physician teams, and whoever other specialities that is involved, maybe endocrinologists likewise. All healthcare workers caring for these patients should have access to these MDT decisions and plans. This is one of the areas that we lack because the plans are not well documented and not well transmitted to other healthcare workers. Another important thing is what to do about the medications. Low dose aspirin, low molecular weight heparin, labetalol, nifedipine, methyl-aldopa, prednisolone, azathioprine, cyclosporin, tacrolimus, metformin and hydroxychloroquine are regarded as safe in pregnancy. And MMF, methotrexate and cyclophosphamide cause teratogenicity, so obviously should be avoided. Rituximab is best avoided due to neonatal B cell depletion. Sirolimus and everolimus, we have insufficient data. And ACE inhibitors and ARBs, statins and loop diuretics for obvious reasons. So what is the approach to care in a patient with pre-existing renal disease? uh, avoiding pregnancy in active renal disease is the best option. So, what is active renal disease? It includes unstable renal functions, active glomerulonephritis, active tubulointerstitial nephritis, first year of renal transplant or recovering from acute rejection likewise. So, in addition, safe and effective contraception to all women with renal diseases should be offered. This includes emergency, long-term and permanent solutions, which whenever necessary. The cornerstone of managing pregnancies in patients with renal disease is pre-pregnancy counseling and optimization of care. So the counseling should be offered by multidisciplinary team, not by the nephrologist or not by the obstetrician alone. It should be a joint effort. The risks to the mother as well as the fetus has to be expressed and preferably should be given as written document. Stabilization of disease activity with pregnancies with appropriate medication is one of the most important things. Any unstable renal function, we don't know whether the renal function problems with the renal functions, whether it is due to the disease or whether it is due to pregnancy. So, stabilization of the disease is very important. Blood pressure control is obvious, less than 140/90. Optimization of glycemic control is important. It may be due to diabetes or may be due to steroid-induced hyperglycemia due to the medication of some of the renal diseases. And the treatment plan in event of relapse during pregnancy has to be thought beforehand, and the patient has to be counseled on this. What will happen during a relapse, and also offer pre-dialysis education if the patient is in advanced CKD stages, that we might end up with 5 days dialysis per day, as well as sometimes expressing that we might need to do dialysis with the advancement of the pregnancy. It could be a new experience to most of the patients. So, going into specific renal diseases, the diabetic nephropathy, pregnant women with diabetic nephropathy may experience worsening of renal function test and proteinuria as well as retinopathy during the pregnancy. So, optimization of glycemic control, blood pressure and proteinuria prior to conception is a must. So, whenever ladies with diabetes plan for pregnancy, pre-pregnancy counseling and pre-pregnancy optimization at least up to 6 months should be offered to them before they go for pregnancy. Women with diabetic nephropathy should continue angiotensin converting enzymes and ARBs until conception, with regular pregnancy testing during attempts to conceive. Most of in our settings, these pregnancies occur as accidental pregnancies. So, whenever possible, whenever you diagnose diabetes in these ladies, they has to be properly followed up to prevent any accidental pregnancies. And most importantly, national guidelines are needed for managing diabetes as well as diabetic complications in pregnant patients. Glomerulonephritis. These could be pre-existing, relapsing, or de novo. So, the most important thing is the tissue diagnosis doesn't matter much during the pregnancy. What matters most is clinical parameters like hypertension, proteinuria, renal functions, and presence of urinary tract infections. Going into specific types, IgA nephropathy has a high risk of relapse during pregnancy, and Henoch-Schönlein-Purpura is triggered by pregnancy. Although it's a not a glomerulonephritis, adult polycystic kidney disease with normal renal functions and blood pressure, there is no added risk in pregnancy. And the problem is when pre-existing hypertension and CKD is present, it increases the maternal and fetal risk. So, polycystic kidney disease rarely causes severe fetal growth restriction due to lack of space, because when at the time where the lack of space is a problem, the renal functions are extremely impaired, and it usually affects the fertility as well by that time. So, lupus nephritis, best outcomes are achieved in patients with inactive lupus for more than 6 months before conception. So, inactive lupus is where you don't find any clinical findings of active lupus, arthritis, thrombocytopenia, anemia, normal complement levels, normal ESRs, normal CRPs, no proteinuria, or controlled proteinuria, stable proteinuria. So, these are the features of inactive lupus. The renal flares present with proteinuria, hematuria, hypertension and falling GFR, which has to be identified and treated promptly. And distinction from preeclampsia is difficult. Low complements help, but it's not a diagnostic, it doesn't have much diagnostic accuracy. So it is basic, it finally comes down to your clinical judgment and experience. So these patients has to be screened for anti-SSA and anti-Rho to assess the risks of fetal heart block as well. So these are basically the outline of the management. There are a lot more things happening, but this is basically the outline of management what we practice when you have a lupus nephritis, mother with a lupus nephritis. All patients expecting conception should be reviewed for fetal-friendly drugs and should be allowed to establish on them for at least 6 months. This is a very important thing. Hydroxychloroquine can be continued throughout the pregnancy unless there are contraindications, ophthalmological contraindications. Steroids, azathioprine, cyclosporine, tacrolimus, IVIG and plasma exchange are all safe methods in pregnancy. So, depending on the severity of the disease, you might need to offer one of these treatments. So, it could be associated with secondary antiphospholipid syndrome, which can be treated with low molecular weight heparin throughout the pregnancy and 6 weeks postpartum. So, other types of glomerulonephritis, 3 to 6 months of remission is needed before conception. Once again, maximum optimization of the patient before conception is needed after converting to pregnancy safe immunosuppressive agents that I have discussed in the at beginning of my talk. And the type of glomerulonephritis will decide on which kinds of treatment to be initiated during the pregnancy. Then we come to chronic kidney disease in pregnancy. So, the risk stratification is done as mild, moderate and severe, where the serum creatinine is less than 1.5 is mild, 1.5 to 1.9 it's moderate, and more than 2 severe. The effects on renal disease is increases with declining renal function, as well as effects on pregnancy outcome from preterm labor to IUGR, preeclampsia and preterm labor, and fetal death with worsening renal functions. Proteinuria is also a risk factor with more than 500 milligrams per 24 hours of proteinuria is associated with growth retardation, preeclampsia and preterm labor. Hypertension we have already discussed how it affects the pregnancy outcome, urinary tract infections as well, and hyperglycemia. All these things affect the final outcome. Assessment of the renal functions during pregnancy is done using serum creatinine because the EGFR is not validated in pregnancy. So women with CKD have formal quantification of proteinuria in pregnancy as for any CKD patient. This quantification can be done using urine protein creatinine ratio, urine albumin creatinine ratio. 24-hour urine collection is bit of a overkill. These two simple tests is okay. Once again, pre-pregnancy counseling as usual regarding increased maternal and fetal risks, and discontinue inappropriate medications like ACE inhibitors, statins and ARBs. Aspirin and folic acid as usual, and women established on hemodialysis prior to pregnancy receiving long frequent hemodialysis, either in center or at home, which was discussed by Ramesh in detail. During the pregnancy, urine culture and appropriate prophylaxis should be started. Thromboprophylaxis when nephrotic range proteinuria with more than 3 grams per day proteinuria, or when associated with, even if lower, if it is associated with risk factors like smoking or advanced maternal age, obesity or immobility. Blood pressure target less than 140/90. Creatinine, hemoglobin and baseline ultrasound scan KUV for comparison. And women receiving hemodialysis during pregnancy have dialysis dose prescribed, aiming at lower pre-dialysis urea levels, less than 12.5 millimoles per liter, 15 in some guidelines. So any patients on chronic continuous ambulatory peritoneal dialysis has to be moved to hemodialysis during pregnancy, obviously due to issues with the space. Postnatally, close monitoring of blood pressure and fluid balance has to be monitored. Continuation of heparin and return to pre-pregnancy medication 2 weeks after postpartum. Termination of pregnancy is also a modality. This might become necessary in some pre-existing renal diseases. The decision is taken depending on the risk of fetal or maternal complications. And the decision is easy at each end of the spectrum, but difficult in the middle when it is really grey. So other than for disease activity, do we need to consider other issues like subverted non-planned pregnancy or family circumstances? It's a issue. If it is an issue, what are their ethical implications? These things need to be further looked into. So for termination, the high risk categories would be teratogenic medication, it's a fetal risk, and serum creatinine more than 2. The medium risk ACE inhibitors, ARBs, statins or creatinine between 1.5 to 2, and low risk when they are on furosemide or CNIs like tacrolimus or cyclosporin. So in conclusion, women with renal disease needs pre-pregnancy counseling and plan of care by MDTs. Renal disease is not a barrier for fertility, and plan for success as well as failure in advance and convey it to the family. And there are important things to consider, that you have to go for collateral histories always, and always keep your clinical, always use your clinical judgment, because in the case of drug compliance during pregnancy, everybody lies, you know who it is. And when it comes to termination of pregnancy, whether to offer it or not, every baby is precious, but that is George Orwell. All animals are equal, but some animals are more equal. So we have to consider these things. Thank you.